first speaker, who is going to be, it's going to be interesting. Well, actually, you can remain seated. We'll pass the microphone to you. That would be Dr. Lurla Joseph. So, Dr. Joseph.
Good evening. I was asked to talk about the problem. I've actually practiced medicine, and I don't like to tell this too often because then people try to guess my age, but I've been practicing medicine now for 29 years. The first 3 years I practiced medicine in Detroit, Michigan. And at that time I did not have to be concerned about whether or not my patients could pay, because I worked for the National Health Service Corps. And whether they could pay or not, I would see them. Then I moved to Richmond, Virginia, and I've been burdened with that ever since, whether or not they could pay. The problem is immense and has only gotten worse over the last decade. You have heard the various numbers and statistics, and I will rehash those, but then I want to just mention a patient example that I see on a regular basis. It will not be a patient who is totally uninsured. It will be a patient who has had insurance and had the benefit of insurance all of her life. But then also the other part of the problem that we see with healthcare is that healthcare costs too much. So in a sentence, healthcare costs too much and it doesn't cover enough people. We know that we spend over $2 trillion a year for health care in this country. We spend 50% more per person than the next costliest nation in the world for health care. $2.3 trillion on health care, which comes out to about $7,000 per person. The cost of health care for the average American family is $16,771. Now, I practice medicine and I have medical assistants who work for me. I have receptionists, and some of my receptionists do not make $16,000 a year, unfortunately. Half of all bankruptcies are related to medical expenses. Those are just those big numbers that we hear over and over again. What is the urgency of this? 47 million Americans are uninsured. In the year of 2007 and 2008, 87 million people were uninsured at some point in time during those years. That's an astronomical number in a country like the United States of America. Even people who have insurance have difficulty accessing care in certain parts of the United States. When I lived in, worked in Charles City, and I don't work in Charles City anymore. I was there for 10 years. But when I went to Charles City County, which is about 35 miles from Richmond, I was the only practicing physician in that county. So even if you had insurance, there was a possibility that you may not be able to get in to see me on Tuesday evenings and Thursday evenings when I was in Charles City County. What are some of the other problems with health care? It is not working. We as physicians find ourselves spending more hours doing paperwork on the telephone, doing prior authorizations, patients who have been on stable medical regimens for years switch their insurances, and then we have to redo their whole regimen of medication. We have to change their specialists who they see. It is not working. The problems that need to be fixed should be fixed. I believe that health care has many problems, and I believe that single payer will answer lots of those problems. It won't answer all the problems, but it will be a good start. We need accessibility, we need affordability, and we need doctors to be healers. I did not go to medical school and get an MBA to negotiate with the insurance company about what my fee should be. I did not go to medical school to become a research analyst as to comparing the various types of of procedures that one insurance company says it's okay, the next insurance company says it's not okay. We have a real problem spending more time speaking with administrators than seeing our patients. What are some of the other problems that we're seeing with healthcare? 5 of the costliest illnesses and conditions in the United States are preventable. These include cancer, cardiovascular disease, diabetes, lung diseases, and strokes. These can be prevented. But we do not spend any money on prevention in this country. Only 4 cents of every dollar is spent on prevention and public health. Only 4 cents of every dollar. When I see a Medicare patient for an annual physical, which includes preventive care, for females who need to have pap smears and breast examinations, I cannot bill for prevention. I have to bill for a regular office visit and code it as if I saw them for their hypertension or their diabetes. Because Medicare does not pay for prevention. And so we have a real problem in this country where we're focused on treating diseases and not treating or preventing diseases. And so we spend a lot of time doing quantity of care and not quality of care. Doctors want to focus on prevention and doctors want to focus on wellness. In my practice when I started, I had, my motto was improving healthcare through diversity. That diversity meant that if you came to me and you were sick and you had a disease, I would diagnose it and I would treat it properly. But I also focused on prevention, I focused on community service, and I focused on diagnostics. So I wanted to give a comprehensive treatment, but most of my time is spent on treating diseases. You don't get enough time, you cannot bill adequately when you're sitting down talking with a patient about prevention. Talking to a patient about cigarette cessation and helping them to understand how they have developed a habit is not reimbursable. They want you to talk about it, but most often it's as the patient is walking out the door after you've written your prescriptions and told them what specialists to see. Then you say to them, and oh, by the way, I want you to quit smoking. So we don't get an opportunity to spend time on prevention. Again, the system rewards the quantity of care rather than the quality of care. There have actually been studies to show that if you have a heart attack and you have insurance, you're as more likely to die as the person who doesn't have insurance. And part of that is because we do not look at what all the time is effective in treating a condition. In the New Yorker, there was an article about McAllen, Texas spends twice as much as El Paso, Texas in the improvement in health. So we have these disparities in care, and we need to become more uniform in the way that we treat patients. Finally, you've heard about comparative effectiveness research. The President is interested in allocating funds for this so that we can begin to compare the effectiveness of certain treatments. Less than 1% of our healthcare spending goes to figuring out what treatments are most effective. It can take up to 17 years for research to find its way into an exam room or operating table. The goals of reform should include research to identify what works and facilitate rapid implementation of what works in our practices. So this is an overview of part of the problem. But then I'd like to just kind of bring it home, because as we talk about statistics and as we talk about numbers, people get lost in that.